Hi, I'm going to make this very technically challenging to understand so that you fall asleep and then you thank me for it. So my job here is to talk about a pill that we've made called Imusil, which helps in the treatment of COVID, long COVID, and one of the side effects of it is it decreases belly fat. But instead of me talking about the pill, I want to talk about how we actually went about making the pill. And the reason why I want to do it because it may actually help you to understand what is the difference between you getting mild COVID and you getting severe COVID, and why is it that 40% of people who have COVID end up getting long COVID and suffer for years altogether. So let's go to what happens in your immune system. Let's say the COVID virus is entering through your nose, yeah? It's entering through your mucosa. The first thing that happens in your body is that there's a barrier membrane, which is your mucosa. And there's a certain cytokine that is released by your epithelial cells of your mucosa, known as interferon lambda. It's called as type 3 interferon. This guy actually brings inflammation down and repels the virus off. But this COVID virus is very, very intelligent. It has something within its RNA which makes it look like human RNA. So human RNA has something known as a 7-methyl guanosine cap on it. And because of that cap, that is what makes human RNA how it is. So that whenever an infection enters inside your cell is able to say, oh, this doesn't have that 7-methyl guanosine cap. This is a foreign infection, I need to attack it. But COVID has the ability to put that cap on. So it escapes interferon lambda and enters inside your body. At that time, if you can trigger the release of interferon lambda, the virus will not enter. So the first target we had in our mind is we need to create something which increases the levels of this interferon lambda. Now let's say the virus is broken through and has entered inside your cells. It has gone into your epithelial cells of your lungs. The virus now infects one of your cells. And because of its little cap that it has, your cell cannot recognize it's there. That cell which the virus infects is dead. Now that virus is going to spread to other cells in your body. The moment the virus escapes out of the cell, there are certain cells within the vicinity known as PDC cells. They secrete another cytokine called interferon beta, called as type 1 interferon. If that does not happen, and this is what differentiates people from who have mild COVID versus those who have severe COVID. Patients with severe COVID either have genetic defects in the ability to make type 1 interferon, or they actually develop antibodies to type 1 interferon. So your body is attacking the same thing that is going to help it eradicate the virus. So these patients now are going to get severe COVID. So again, the interferon lambda first, the virus is broken through the barrier, now entered your cell, it's killed off the cell, it's spreading to other cells, but interferon beta is not there. If interferon beta was there, the other cells of your body start going into the state of aggression, and they go into a state known as the antiviral state. They start making interferon beta without the virus even entering. The moment the virus tries to enter it, the interferon beta activates enzymes like PKR and slice the viral RNA into bits, and the virus is dead. So we needed to have a product which increases interferon beta. But if you guys are aware of type 1 interferons, there are two types of type 1 interferons, interferon alpha and interferon beta. If your body has an increase in interferon alpha by mistake, you're going to get clotting and your D dimers are going to shoot up. So we had to be very specific and say our drug is only going to increase one aspect of the type 1 and not the other type of type 1. So this was the second molecule that we needed to activate. After the virus has entered inside all your cells, there's no interferon beta anymore. The virus has one more trick up its sleeve. It activates certain other enzymes in the body. For example, the first enzyme is COX-2. If you guys have heard of COX-2, COX-1 is used for housekeeping. So if your cells are dying, COX-1 increases and your body is able to remove the dead cells. But when you have a viral infection or some other infection, COX-2 increases. Along with COX-2, there's another enzyme known as P38 MAP kinases which increase. When the virus induces them, the COX-2 goes and secretes TNF-alpha, increases interleukin-1 and interleukin-6. What does it mean for the patient? They start having fatigue. They start having fevers. And when you see in the white blood cell counts, you see the neutrophil count going up and the lymphocyte count dropping, which is what you see in the blood reports of patients. The virus also has one more trick up its sleeve. It increases an enzyme called as NOX2. The moment NOX2 increases, the neutrophils start taking iron and they convert that iron via Fenton reactions into oxidative stress. They're trying to burn the virus out. But NOx2 is only useful when you have a bacterial infection, not a viral. So your body starts getting burnt out from inside, which is why they say, oh, give vitamin C to the patient. But vitamin C is not going to help you, because vitamin C is the end molecule that receives the oxidative stress free radicals. It's not stopping the enzyme. So as the NOx2 levels increase more and more, your ability to make type 1 interferon decreases further, because NOx2 blocks the formation of type 1 interferon. Now you have severe cytokine storms, your neutrophil counts go up and the lymphocytes go down. So the fourth molecule that we had to target was NOx2, we had to inhibit it. After the virus is spread into your body and killed off a whole bunch of cells, the first cell that goes and removes those dead cells are your NK cells, your natural killer cells, which are also required when you have cancers. The virus blocks a cytokine which allows those NK cells to grow, called as interleukin 15. So it lowers the level. So that means we knew we had to increase that level as well to make our NK cells function. Now comes the day 5 or day 6 or day 7 of you. You have COVID and you're slowly worsening. By around the 7th day, you're supposed to form antibodies. If you don't form antibodies, you start getting worse. If you've seen after day 10, if your COVID is not treated and you have continuous fever, you end up getting really, really bad. So doctors tell you, well, day 10 is going to be a dangerous day for you. If you survive that day 10, you have good chances of making it through. But if you don't, you're going to be in bad shape. So by the 10th day, your body has to start forming antibodies. For that, you require another interferon, known as type 2 interferon. And the virus has the ability to even block that one. So we had to create a molecule to increase type 2 interferon, called as interferon gamma. By day 10, okay, if you have not formed those antibodies, now what happens is your T cells, the ones which remove the infection along with your B cells, your antibodies, they start having exhaustion, they get tired, which means that the T cell is in the vicinity of the infected cell and it does nothing to it. Why does the body do this? Because just imagine, so many cells of your body are infected already. If your T cells were not naturally exhausted, they could actually worsen and kill you. Which is why T cell exhaustion is something that saves you from severe COVID, but at the same time allows the COVID virus to spread. So we require to reactivate those T cells. And we chose a very interesting method. We chose histone deacetylation as a method to revive it. So histones are basically like little blocks of wood, and the T cells DNA winds around them. When it winds around them, it is not able to get red. So we needed something to expose the histone out, to remove the histone out. So we take out the histone, the T cells DNA starts getting red, and the T cell exhaustion starts getting overcome. So all these molecular targets we needed to hit. And what we did is by using 3 simple herbs and using specific extraction technologies on them, we were able to construct 87 molecules from those herbs in order to target all these pathways. So that's what I'm here to talk to you about how we have targeted all these pathways and why things like vitamin C, vitamin D, vitamin zinc, zinc can sometimes be so dangerous for you. So let's look into what we've done. So this is a pill, it's just 3 herbs. It's picoриza, which is a very common herb, Tinospora, and Embolica, which is your amla. Using various different extraction methods, we extracted these molecules out. We used UV spectrum, FTIR, GM in order to isolate what these molecules were and concentrate them inside the extract. So I've already explained what happens in COVID. There's a decrease in the type 1 interferon, and there is an increase in your neutrophil counts. So patients have symptoms of fever. Because of that COX-2 elevation, they're going to get fever. Okay? If your fever doesn't go down, that means your COX-2 activation is happening and the virus is spreading. So when patients take my pill, the fever starts to go off within just a couple of hours, and the patient's fatigue also starts to increase. So these were the molecular targets that we targeted: TNF, IL-1, IL-6, the HDAC and all has not been mentioned here, IL-15 also has not been mentioned. But we are running now specific tests in rat models to check for those enzymes. So we were helped by the Department of Biochemistry in Kerala. We were helped by the International Center of Genetic Engineering, who did a 0E6 trial for us. We were helped by the Indian Institute of Science and by the IOS department to create our drug. So what did the International Center of Genetic Engineering do for us? So they did a trial on BRO-E6 cells. These are cells which have the capacity to make interferon, but they don't make it. So when the virus entered inside the cells, all the cells got infected. And when our pill was put into contact with the cells, the virus died in the cells because the cells were able to make interferon. Which means even though the virus had that cap, which made it look like human RNA, yet your body was able to make that type of interferon and destroy the virus. So this is the study that we did. The first one was on the BRO-E6 cells. After that, we did studies on PBMC models, which are your human cell lines that we tested on. Then we did a rat model of it, and finally now we are doing a 100-patient human trial on it. So we had a 71% decrease in the viral load within 24 hours on the BRO-E6 cells. Now, you think that 71% is a lot, but it's actually not. If you see a drug like remdesivir, it had 99% decrease in this cell lines trial. But does remdesivir work? It doesn't. Why not? Because it doesn't target the rest of the inflammatory parameters. So just killing the virus in the cell is not important. You need to decrease inflammation in the body. That's what we did. So we checked the level of inhibition of NOX2, COX2, and TNF, alpha, and IL-6 and IL-1. All of this we checked. So this is what we're going to show you. So this was the data that came back from the International Center of Genetic Engineering, where we showed that this was the inhibition in the viral load. Go back. So this is the NOX2 inhibition. If you see the control, there's hardly any expression of NOX2. When LPS was added to the cell line, you can see it's a very dark layer over there. And when LPS and Imusil were giving, it's actually lighter than the original. So NOX2 was so inhibited. NOX2 is not just important in COVID, it's important in diabetes. So the side effect of a pill, it causes abdominal fat loss. Not a single patient of ours who has started Imusil for COVID or long COVID has ever stopped it because of the continuous decrease in the waist loss that they experience. Blocking of COX2, as you see, when LPS was added, the level of COX2 really increased, and when Imusil and LPS was added, COX2 expression was not that high. It was almost equivalent to your normal symptom. Now, in patients with COVID, they end up getting lung fibrosis. If you see, about 40% of patients who are hospitalized with COVID end up getting lung fibrosis. My own aunt and uncle who are in the US, they have developed lung fibrosis, which is terminal after COVID, within 1 year. It's not like it just happened within 6 months. It took 1 year for them to start developing a cough, and they went for an X-ray and a CT, and it showed that they had lung fibrosis. So by blocking COX2, you decrease fibrotic activity in the lung. The antioxidant activity is the coolest. If you see in your normal cells, there is there's like one green spot. That's the amount of oxidative stress that was there. And after adding LPS or bacterial enzymes or viral enzymes, that whole green thing is the amount of oxidative stress. And then we added Imusil to it, almost nothing. It's back to normal. Now this actually makes Imusil the best antioxidant ever. It's not just your ORAC value that determines oxidative stress. That is the capacity of the antioxidant to absorb the oxidative stress. Even glutathione has the ability to absorb oxidative stress. What about stopping the enzyme which is causing that oxidative stress in the first place? That's what we have targeted, and that's why our pill is so much better. We've taken this to the next step where we've developed a urine test, and I hope within a year all of y'all can do it. So the urine test, you give a urine sample. Using ELISA, we can check an oxidative stress marker called as 8-isoprostane. For most people, the 8-isoprostane levels are very high. No matter how many antioxidants you take, how much of vitamin E, vitamin C you take, that 8-isoprostane is not going to drop because it detects the amount of oxidation to your DNA. It shows how your DNA is fragmenting because of that oxidative stress. So when we give patients Imusil, that 8-isoprostane level drops back to normal, which means it's also a life extension pill. These are the clinical findings, that it helps to decrease fatigue and fever within a few hours. The patients continued Imusil after recovery because it improved the energy levels and fatigue. The fatigue here is because of simple NOX2 activation. It also started to decrease abdominal fat, tremendous amount of decrease in the abdominal fat. And long patients who had chronic fatigue improved dramatically. Now, why does long COVID happen? There are like 4 explanations for it. First one is that you start forming autoantibodies. So this virus is tropic for certain cells. Tropic, that means it likes to go to certain cells. And it enters inside gastrointestinal cells, lung cells, cells even of your testes. We've seen patients having testicular inflammation after COVID. Their testes become really huge and large, which is not a good thing. And these cases, when Imusil was given to them, all those symptoms started to disappear because those autoantibodies are forming since that virus is remaining latent in the cell. The antibodies which were formed against COVID are now attacking your normal cells. And all of this is happening because the cells were oxidatively damaged in the first place. So by blocking NOX2, you stop your body from forming autoantibodies against the cells. Okay? The second theory is that in COVID, there's reactivation of Epstein-Barr. If you guys know what Epstein-Barr is, it's like a chronic viral infection which infects about 80% of us. 80% of us will have high titers IgG against EBV and CMV. When COVID happens, we've seen Epstein-Barr reactivations in patients who get herpes. If you've seen, in the US alone, they have now mandated that acyclovir has to be given for almost a year after COVID because it causes retinitis. Your eyes get inflamed after you get COVID. So, since our pill has the inherent ability to increase type 1 interferon and type 3 interferon as well as type 2 interferon, it keeps that Epstein-Barr in check. We've used Imusil even in patients with herpes and we found amazing effects of it. The third theory of why long COVID happens, and this is a pretty neat little one, is that when you have COVID, you want to have low levels of a cytokine called as interleukin 10. This interleukin 10 is something that stops antigen presentation from happening because you want antigens of your immune system to present those viral particles and get your adaptive immune system active. But if you have too much of IL-10 expression, you have lingering sort of nascent inflammation inside your body. And since my pill has the ability to block that IL-10 as well, we are able to treat patients with long COVID. So patients who developed diabetes after COVID found improvements in their glucose levels. Now we had the Labour Commissioner of Bombay who came with an HbA1c of 14.9 to us. She came in December after having COVID. Yesterday when she checked her HbA1c, it was 6.9 after being on Imusil. She should have actually been on insulin. She should have been on a whole class of oral anti-hyperglycemics, but she only took Imusil. This is how well it works. So I've already explained why the long COVID happens, including the immune exhaustion and how Imusil can work to block it. Now let's see just 2 stupid photos which I have of my doctor friends. But before that, let's see what happens with all the common treatments. So you've seen Dolo getting sold in the market like anything. It's the most popular drug. That is a COX-1 and a COX-2 blocker. If you use a COX-1 blocker on a viral infection, you're going to make that viral worse. So people who are taking Dolo are getting worse because it's a COX-1 blocker. You shouldn't be taking it. You should maximally take a paracetamol. Never ever take Dolo when you have a viral infection. It increases ACE2 and can actually cause viral procession. So if you're an obese person and you're hypertensive, you already have lots of ACE2, soluble ACE2 receptors flowing in your bloodstream. Now you take an NSAID like Dolo, you're making yourself far worse. Next thing, what about vitamin D? It's a great thing because it blocks NOX2, it has some antiviral effect as well, but even that increases ACE2. The other thing that vitamin D does is it depletes the level of an antioxidant in alveoli called as clotho. Has anybody here heard of clotho? Okay. So clotho combines with a substance known as FGF21 in your kidney and dumps phosphate out of your body. If you give vitamin D to a patient with renal failure, who even has mildly elevated creat, you'll see his creat gets worse. This is in any patient who has renal failure. If you give vitamin D, you're going to make him worse. Because that vitamin D is depleting clotho levels. In a COVID patient, if you give him vitamin D, his clotho and his lungs are depleted, allowing the alveoli to rupture. So vitamin D can be dangerous in COVID as well. How about zinc? We had a very interesting case of a patient in Malaysia. He was having mild dementia when he got COVID. And after COVID, he forgot his own name. So we asked him, what the hell have you been taking? And he was taking zinc. Zinc increases the formation of beta amyloid in the brain and it's neurotoxic. So when you take excessive zinc for COVID, you're going to get not only dementia, but you're also going to get mucormycosis, which killed a whole bunch of people in India. Zinc actually elevates the rate of fungal infections, including mucormycosis. How about vitamin C? It's pretty harmless, right? You guys all say, oh, you can take some vitamin C. Anything more than 2 grams is going to increase oxidative stress and can cause you pleural effusion when you have COVID. But more than 3 grams is an advantage because it increases interferon beta. How about if you take less than 2 grams? You know, a little bit of 500 mg of vitamin C. What harm is there in it? Nothing. It doesn't do any good either because as a last carrier of those free radicals and then it has to give it to glutathione, it's doing nothing for you. So don't waste your time taking it. Now, I'm now going to go into the uses of Imusil. Well, I'll just show you some cases that we've done. So this is a doctor friend of mine. You can see his belly was really out. He was severely diabetic. His fasting insulin was somewhere around 45 or 50. And even with intermittent fasting, his blood sugar would not come down. That is just after 3 weeks of taking Imusil from there to there. We've had so many patients, around 35,000 odd, and all of them have said that that's the kind of change that they've had in their abdominal fat because of simple NOX2 inhibition. So diabetes is a complex disease, right? You have many pathways that can lead to diabetes. You have your polyol pathway where you start forming too much of sorbitol. You have your ROS pathway due to PKC activation. You have the bradykinin pathway, you have the RAS pathway, the whole gamut of stuff. But in his case, it was peculiarly because of ROS, because his condition had become worse after COVID. So what we are planning on doing now is we are going to test patients for 8-isoprostane. If that level is high, we know for sure if Imusil is going to work on their diabetes. If that isoprostane is not there, we know for sure Imusil might not work on their disease. So now we have created a nutraceutical with a specific test and with a specific pathway mediated treatment of diabetes. This is a patient on a fracture case. He had a fracture for more than 2 years, his leg was swollen. And that's after about 10 days of giving him Imusil. You can see the entire swelling is gone. This is again because of its specific inhibitory power on COX-2. I didn't put one ultrasound photo. We are calling that the Imusil baby. This was a 42-year-old patient with 3 failed IVS with PCOD. After a month of Imusil, she got pregnant. I didn't put up the ultrasound. So that's the thank you from me. I have finished 2 minutes over time. Thank you.
Great. Thank you so much. Very interesting. Any questions for Dr. Tariq, please? Yeah.
Very interesting studies, Dr. Tariq. I had one question. You mentioned the role of Imusil in COVID and post-COVID and also reduction in belly fat. So do you have any studies where you have done in non-COVID cases or patients for reduction in belly fat?
Me. So it helps me keep my belly fat down and it's helped a lot of my patients. So we've had a lot of people coming to us after seeing their bells start to go inside, asking us for it. But as I said, we need to check their oxidative stress because NOX2 can increase in a whole bunch of diseases, like you have infections in your body, chronic infections can increase it. Certain foods, like if you have a McDonald's burger every day, your NOX2 level is going to be sky high. So if you're going to have all these nasty foods, your NOX2 level is going to go high. Okay? So we can check that 8-isoprostane, say, oh, this is high, you need to take our Imusil. But you can also be deficient in antioxidants in general, your glutathione level could actually be low. We have also a pill which is already launched in the market called as glutathione, where we made an oral glutathione which is absorbed inside your body. We have an international published paper on it, where we've actually checked its effect on the polyol pathway, and we have an international published paper on it, making it the only glutathione in the world which can be orally absorbed without it being liposomal. So based on this really specific test, we can tell you if that Imusil is going to work or not.
Hi, Dr. Tariq. I have a two-part question. First is, all of these studies, were any of the patients in ICU and were they diagnosed as severe COVID? And the second part of question is that we've been discussing so much, and after going through your
presentation that there's so much of studies and data which is available for the role, the entire mechanism of inflammatory actions and basically response to an infection, and the nutritions that can actually play a role. But we still don't see, at least in India, that being and given that much weight and importance in patients who are in ICU. So in patients in the ICU who would need and who would probably, it could be a life and death sentence for them, and it could be a game changer. While there is of course there's a lot of things that doctors in ICU have to manage, but this somehow still gets neglected even in the top hospitals, private hospitals in India, where there is some progress. There's some, because nutritionists are playing an important role, but not to the level that you are discussing here. Right?
So you know the doctors whom we have trained outside India, in Malaysia especially, there they use it even in the ICU setting, and we have treated severe COVID cases. In India, not a single hospital has agreed. So I'll tell you our first case. This was in Gujarat, where there was a rich builder's brother who was dying of COVID, and the doctors told him, well, you may have like a day to live. And the patient's brother, who knows me, told the doctor that we need to give this patient this medicine. So the doctor said, oh, it's herbal, it's all bullshit. I said, okay. Then we showed him the studies we did on it, he wasn't convinced. Finally, they had to have a fight with the doctor and actually physically intimidate the hospital, and then the hospital gave it to him and the patient survived. And in memory of that patient surviving, that patient started a hospital in Gujarat free of cost. So they actually bought an entire building out, since the guy was a builder, and he set up a hospital within a month's time, and they gave everybody free treatment there. The hospital was being run by the BMC there. Okay, so those BMC doctors refused to give my pill to those patients, even though the same pill had saved the fellow who started the hospital in the first place. So it's really shocking. In fact, that patient's name had come in media that spread to UK and to many countries of the world that he survived COVID. In the terminal stage. He was the first patient in Gujarat who survived on a ventilator, who survived after being on a ventilator thanks to my pill. But in India so far, we've not been able to convince any doctor to use the pill. That's the unfortunate truth. Even with so much of data, even now that we are doing a 100-patient human CTRI approved trial, yet even if you show the trial data to the doctors, they don't want to use it. So that's really sad. They would prefer to use remdesivir, which is a failed drug, on a patient rather than use something with scientific evidence behind it. And that's one of the things I feel really sad about, that people see nutrition or herbs or nutritional supplements in a very poor light in our country. Especially as doctors, we are not really trained in this, and we always are taught that the only thing you should tell a patient is kuch to healthy kha lo. That is our basic knowledge of nutrition. Healthy khao, khatam ho gaya nutrition ka full 2 marks ka answer. There is nothing else that we need to know on it. Yeah, B complex de do maximum, just take a B complex. So at the end of every doctor's prescription, you'll see a sad B complex mentioned there. In pity, the doctor writes it. Le yaar, abhi ja tu. That's how it is. It's really sad, and that's why I'm trying to go for these conferences, just to hopefully get somebody interested in doing it. Thanks for your question.
So, last question.
Yeah.
It's a wonderful presentation, Dr. Tariq. I just want to understand what you will call this, because if doctors are not prescribing after giving so much of demonstration and these many studies which you have shown just now, so is this the failure of the system and perception of these technicalities, medical technicalities towards the herbal life and shifting towards this? So in what way you will, because
there are two problems in this. The first thing is that the doctors in India especially believe that all herbs are time pass. And the second thing that doctors believe is that there is no such thing as immunology. They do not understand immunology at all. So if I talk to even MD doctors in India, who are cardiologists, dermatologists, neurologists, when they hear me talking on immunology, they fall asleep. So what we have done is now we are getting, like how I've done in other countries, where we get doctors who are interested in understanding the immune system. We train them in depth on immunology, and then they understand what this is doing. So it's the reverse way out. We don't make them understand what this pill does. We explain to them what is the immunology of COVID, how viral infections enter and spread in the body, how do we go about treating such things. So we help them, for example, Like the doctor will tell you, you know what, your ferritin is raised. And you ask him, what does it mean? He's like, pata nahi, ferritin raised there. What are you going to do about it? Pata nahi. You know, the doctors don't know how to treat simple things like an elevated ferritin level in you. So we tell them why ferritin is elevated. If you ask a doctor, doc, in my COVID, my LDH is still raised. What does that mean? The doctor is like, LDH raised है, इसका treatment क्या है? पता नहीं. My CRP is raised chronically. What to do? No clue. You know, my neutrophil counts are consistently raised above normal. What to do? No idea. ESR is raised. What to do? No idea. So doctors have no clue actually if any of these inflammatory parameters are raised, what to do. Because they don't understand immunology. Even if D-dimer is raised, maximum what has been done, they put them on aspirin. The recent studies on aspirin show it is literally zero in increased D-dimer rates in patients with COVID, actually increasing the rates of bleeding in patients and increasing the risk of death. You know, during the Spanish flu, which happened about 100 years ago, aspirin was invented at that time. And when aspirin was invented, the doctors at that time thought, oh, Spanish flu, fever, aspirin decreases fever, let's give aspirin. After they started giving aspirin, the death rate increased by 3%. Actually, until this day, it's called as the aspirin death rate, which is a 3% increase in death rate due to giving aspirin. Because aspirin does the same thing, it blocks both COX-1 and COX-2 and can actually spread infections in the body. And yet we are using aspirin with failed evidence, no evidence whatsoever. Why are we doing this?
So
Because
it's
the
a lack
doctors
of
don't understand
awareness.
immunology.
This awareness is required at every level, and when you are talking about these kind of pills, then doctor needs much awareness.
I think the best way to sell a nutritional product to a doctor is first to train the doctor in that field of medicine. So if your nutrition product is going to work on immune pathways, train him on what immune pathways, which immune pathways are there, and what those immune pathways do in the body. Then he gets the confidence about your drug. Don't try to sell a drug to him because he's anyway not going to comprehend it or believe you.
Thank you so much.
Thank you so much, Dr.
Thank you.
Tariq. Big round of applause for Dr. Tariq. Thank you.